Hello, everyone. I'm Jody Glance, and I am going to do some introductions here before we get started. Thank you for joining us today, and I know that people will be joining us maybe a little late, and we are recording this. So if anyone misses this or wants to share, I know that will be available to you later. So again, I'm Jody Glance. I'm the Medical Director of Addiction Medicine Services here at Western Psych, and I'm the Associate Director of Medical Student Education here as well. I serve as an advisor to residents in the women's mental health area of concentration, which is something that my colleague Priyanka Amin and I started when we finished our residency program here, which was almost a decade ago now. And with me here today, I have 4 esteemed colleagues. I have Dr. Priyanka Amin. She is an attending psychiatrist at Western Psychiatric Hospital's Psychiatric Emergency Services. She attended Pitt Med for medical school and did research on physicians' care of sexual assault survivors. She completed residency here at Western Psych, where she participated in the women's mental health area of concentration. Then we have Dr. Karen Jakubowski. She received her PhD in clinical and health psychology from the University of Pittsburgh in 2019 under the mentorship of Dr. Karen Matthews. She completed her clinical psychology internship here at Western Psych, and she's now in her 2nd year of postdoctoral training with Dr. Rebecca Thurston. Dr. Jakubowski's research investigates the physiologic, psychological, and social correlates of midlife women's cardiovascular health, including trauma exposure, and women's self-silencing of emotional expression in their intimate relationships. And Dr. Jakubowski currently has a K-23 application under review at the National Heart, Lung, and Blood Institute, and that aims to study the impact of intimate partner violence on sleep and subclinical cardiovascular disease in midlife women. Since 2013, she served on the programs and outcomes committee. I hear a little noise, so I don't know if that.
Could we please have people mute themselves?
Thank you. And someone please mute their microphone. I don't know, Jeannie, if you're able to do it on your end.
I am. I'm going through the list now and muting everybody that's open except our speaker.
If someone could mute your microphone, please. If everyone could mute your microphones, please.
Yes. I'm going to mute a couple of people that look like they've joined by their phone.
Okay. I don't know if there might be a way to just mute everyone.
I don't want to mute you, though. Okay, I believe we're okay now. Thank you, Dr. Glance.
Okay, thank you. And then we have Amy Boyles. She's a licensed clinical social worker at the VA Pittsburgh healthcare system. She attained her master's degree in social work with a specialization in mental health from the University of Pittsburgh. She began her career as an inpatient psychiatric social worker here on the dual diagnosis unit in Western Psychiatry. At VA Pittsburgh, she works with substance use disorders, homelessness, polytrauma, and suicide prevention. She serves as the Intimate Partner Violence Assistance Program Coordinator for VA Pittsburgh and is the Regional Lead Coordinator for National IPV Assistance Programs. And then we have Janice Goldsborough, who has been the Medical Advocacy Coordinator at the Women's Center and Shelter of Greater Pittsburgh since 2007. She previously worked at Allies for Health and Wellbeing, formerly the Pittsburgh AIDS Task Force, and the Women's Center of Beaver County. She serves on the UPMC McGee Intimate Partner Violence Task Force and the UPMC Mercy McGee Community and Hospital Forensic Advisory Council. So thank you all for being here with me today for this really important topic. And I just wanted to, I should have had that slide up while I was introducing everyone. My apologies, but these are our presenters. And before we get started, just a disclaimer that, we know this is a really sensitive topic, and we'll be sharing very, very briefly with not much detail a clinical case and then some examples of types of intimate partner violence that can be triggering. So we just want you to be aware of that in advance. So if you need to step away or step out at any time, that's completely fine. As I mentioned, it'll be recorded. If you want to come back to it later, it's completely okay. So just briefly, I wanted to mention how this topic came about. So the idea for this grand rounds grew out of a root cause analysis that we had for a patient at NATP, which if you're not familiar with our program, that's our opioid treatment program, our methadone program. And we learned that a homicide had occurred, unfortunately, where one of our patients had taken the life of his partner, who was also our patient. And the two had been intimately involved for years. They had children together. She had, throughout the course of her treatment, had intermittently expressed intimate partner violence was happening. And it was something that we were frequently assessing for. And also we knew that her partner, as the perpetrator, was somebody we should be assessing. And so this was happening, but in the appointments leading up to the homicide, we didn't pick up on it. It was going well, things were going well from what we knew. And so then we learned of the unfortunate, terrible, horrible outcome. And we just decided that maybe it would be good for all of the clinicians in Western Psych, or not just the clinicians, all of us in the Western Psych community, to have a little refresher on how do we screen, how do we assess, and what steps we might be able to take so that hopefully we can help prevent some of these outcomes from happening in the future. Just briefly, a slide on definitions. So intimate partner violence is what we'll be talking about today, which is abbreviated IPV. So when you see IPV, that's what we're talking about. You may have also heard this referred to as domestic violence. So I wanted to just briefly touch on the differences. So the definition from the CDC in 2016 was what's on this slide. So physical, sexual, or psychological harm or stalking behavior by a current partner or a former partner. And that occurs on a continuum of frequency and severity. It's not just, physical abuse. There's lots of other things on the spectrum that would count as IPV. So it ranges from emotional abuse to chronic, severe battering, death. This can occur in heterosexual relationships or same-sex relationships. It does not matter. It does not require sexual intimacy. It does not require that the people live together. So it's really any kind of physical, sexual, or psychological harm that's happening between partners. Domestic violence, on the other hand, means it's occurring at home. So it's any kind of abuse that's happening within that domestic sphere. So that would also include child abuse, elder abuse, any kind of interpersonal violence, not necessarily intimate partner violence. So the types, as I mentioned, I'm not going to go into great detail on this because I think that's a little outside the scope of what we want to talk about today. But again, the physical violence is maybe what people are most familiar with, and that can include lots of different things like shoving, hitting, kicking, biting, lots of things in the physical side. But emotional abuse can be very, just as powerfully difficult for people and can really be a harbinger of what might come. And this can include things like shaming, humiliation, controlling, coercing, isolating people from other supports, and then sexual abuse. So any kind of unwanted sexual activity, any kind of sexual coercion, this is also in the same sphere. And they overlap, as you see in the Venn diagram here. They might occur on their own, but it's very common that they occur with the other types of violence. And not always at the same time. Like I mentioned in this particular case, we didn't know that it was actively happening, and then we found out it in fact was. And then stalking is another one that, stalking kind of overlies all of it. And stalking is, we could do a whole topic on stalking because it's really complicated. Again, I wish we had time to talk about all of this today, but stalking is a type of intimate partner violence. Okay, so with that, I will introduce Priyanka Amin to talk a little about some common myths about intimate partner violence.
Thank you, Dr. Glance, for that introduction. We're really grateful for this opportunity today to be able to talk about this really important topic. And what I'll be covering in the next 10 minutes or so is just some common myths that we hear about IPV in hopes that we can start dispelling some of the myths and stereotypes that we hear. So one of the first myths that we hear is that IPV only happens to some subsection of the population. This could be the myth that IPV only occurs or primarily occurs to women. And what we know is that IPV, while it certainly is an issue which affects women, is also a very prevalent issue with men. In terms of national data, there's data that at least 1 in 9 cisgender men are impacted by IPV, and that's likely an underreporting given that men are often not screened. In terms of the myth that IPV only occurs in heterosexual relationships, I know Dr. Glance alluded to this as well, but this is an issue that affects the LGBTQ+ community. This occurs in individuals who are not cisgender. It occurs in couples that are, between folks who are not of opposite sexes as well. There's also this frequent myth that IPV occurs to some other subsection of the population that doesn't look like us. And I would say that we're finding more and more in the literature that there's a vast diversity in terms of the professions of folks who are impacted by IPV when it comes to their socioeconomic status, when it comes to their race or ethnicity, when it comes to their professions. An area of interest of mine recently has been looking at the rates of IPV in healthcare workers, including in physicians. And we're actually finding in more data coming out that it seems like these rates are comparable, if not higher, than the national average, even within our own physician communities. There's the notion that IPV only occurs with younger individuals, and I would say that we're finding more and more that IPV also occurs with folks later in life as well. There's this notion of elder abuse or individuals who have been in relationships perhaps for decades, and these individuals being abused as IPV essentially aged up. The reality is that IPV is a cross-cutting issue for all people, and that includes all of us and all of our patients as well. There's this frequent stigma that we do harm by asking about IPV. I know this is something that we're sometimes taught along the way in our medical training or in our clinical training. And the reality is that asking about IPV is something that is accepted by our patients, and universal screening is expected. There's been a great deal of literature on patient perspective. So when you look through the data in terms of the qualitative perspectives of patients, we're finding that patients are not consistently being asked about whether or not they experienced IPV. I would challenge us all to pause and think about when we were last asked, the last time we saw maybe a therapist or psychiatrist or another healthcare worker about our own experiences. And one of the things we know is that patients do expect to be asked. They expect that this is something that healthcare workers are going to be asking them about, and by and large are supportive of being asked about this and discussing this with healthcare workers. There are recommendations on IPV screening. So the U.S. Preventative Services Task Force has a recommendation. It's a grade B recommendation, which means that there's modest benefit. It's something that there's not really harm associated with, and the implication is that should be done throughout. Their recommendation is that we should screen all women of childbearing age. This made me pause thinking about some of the literature I'd seen, and so I read this recommendation more, and the reality is that they're not necessarily saying there's no benefit in assessing IPV in other populations, but rather there's just insufficient data and literature to be able to generalize this recommendation to other populations, ages, and genders. When we look at the American Psychiatric Association, there is a recommendation that we should screen anyone who's presenting with mental health symptoms or concerns. I would say that would be all of the patients that we're seeing here at Western Psych. So that includes in our emergency settings, in our inpatient consult settings, and our ambulatory settings. Whenever we get a positive screen that someone is experiencing IPV, it's important for us to assess their safety and to talk about safety planning, and for us to also do a good lethality assessment like we typically do, specifically thinking about the risk of suicide as well as the risk of being a victim of homicide or violence. Another frequent thing that we hear is that it's easy to leave an abusive relationship, or this notion that, well, this would never happen to me. It's not something that I would tolerate, I would get out of it. The reality is that leaving an abusive relationship is often one of the most dangerous times of these relationships. This is when folks are most at risk of experiencing violence, including homicide. We know that individuals may have to make many attempts to leave before they're successfully able to leave. This is because people who perpetrate IPV are really good at controlling the people who they're doing this to. There's often an insidious onset. It might be something that's difficult to identify early in a relationship. It's also something that over time might be normalized in the relationship. For people thinking about leaving, there's often a great deal of fear and a lot of shame that surrounds the notion of leaving. This can be because perhaps their partner is someone who they've introduced to their family, their friends, perhaps goes to the same school or job that they go to. Uniquely in the LGBT community, there's also this fear of intimidation, the fear of being outed. If you leave me, I'm going to tell everyone that you're non-binary or trans. This is something that is a real issue in this community. We also have to consider the cultural context. So in a lot of cultures, and speaking myself as someone who grew up in a first-generation Indian household, the reality is that in the culture I grew up with, for example, leaving a relationship, divorcing, separating from your partner is incredibly stigmatized and frowned upon. So oftentimes, culturally, there might be times where people continue to endure IPV because of that stigma from their community. Whenever we're seeing patients, we see just them in front of us. It's important for us to realize that there is so much more that all of our patients are thinking about beyond just themselves in that situation. There's the idea that, what are they going to do with their children and their safety, their pets? What's going to happen with their finances if there are joint accounts? What's going to happen with their property if perhaps their partner who's abusing them is the one who has control over it? And what's going to happen to their supports in terms of their professional communities and their personal communities? All these things hang in the balance. So I think that a lot of times, well-intentioned, we think, we need to get people out of this situation, right? Like, this is a bad thing. We want to get them out. We want to help them with what's going on. The reality is that we need to step back and allow people who are experiencing IPV to be able to maintain their locus of control. While we might be feeling benevolent in what we're doing and trying to rescue them or save them from a situation, we have to understand that when people are experiencing violence, they have lost their ability to control what's happening. This is something that their perpetrator has taken. And so we need to be incredibly mindful of this and be able to take a step back and meet people where they're at. This is something that we frequently use in mental health and behavioral health in terms of motivational interviewing. And a lot of these techniques can be really helpful when working with folks. It's also important for us to think about strength-based language. So instead of referring to these individuals as victims, referring to them as survivors and talking about them as survivors. Instead of referring to the people who are hurting them outright as abusers to them, when we know that there often is a strong emotional bond between them and the person perpetrating violence, we need to be able to define this behavior and say, your partner is behaving in an abusive manner. Instead of asking why did you allow this to happen? Why don't you just leave? Seeking understanding and clarity and, asking what and just eliciting that information. We want to be able to support individuals. We want to validate what they're going through, their reactions, that what they're experiencing is not acceptable. We also want to make sure that we normalize and not pathologize normal acute stress reactions. So people who are enduring the sequelae of experiencing violence go through a whole host of cognitive, behavioral, emotional reactions, which are not pathological. It's important for us to offer choices and also to tolerate that people are going to decline these choices, and we have to be okay with that. It's also important that we're mindful of people's safety whenever we're giving resources and when we're documenting. So now with open notes, we have to be very mindful about who is reading these notes, for example. When giving resources and offering them, we have to know, is it going to be dangerous for me to put directly in your discharge paperwork the information that we talked about, because perhaps their partner is the person who's picking them up or is accompanying them to their appointment. We also have to recognize that protection from abuse orders do have shortcomings, and I could talk about that for a whole lot longer. And the one thing to be aware of is that they should never replace a safety plan. So in terms of safety planning, this is something that we can do with patients whenever they disclose that they're experiencing intimate partner violence. This involves having a discussion of, is there a word or a phrase that you could use to alert other people that you're in danger, that you need them to call for help? This is something that we can work with our clients in the office. We also want them to be able to prepare for what items they need in order to make a quick escape if it ever comes to that. There are a lot of folks who, right now they're going to continue to tolerate what's going on, or for their own safety, it's actually safer for them to stay in the current situation. That being said, having a bag or something ready to go with, their birth certificate, social security card, other important documents, cash, medications, change of clothes, also that for any children or dependents that they have. And being really practical about walking through the logistics. So if they were to experience violence or need to make an escape from school or from their work, what would happen then? How could they alert their children if they needed their children to call for help? What would happen to their pets? Who would take care of them? What does their partner have in terms of technology that they could potentially use against them, or any accounts that they control? There are a lot of really great free resources that we can actually get for clinical settings. So Futures Without Violence is a wonderful organization that offers materials it's not just for any one segment of the population. It's actually, they offer a lot of diverse materials for folks in different sexual orientations, different gender identities, different races, ethnicities, religions, and that's something that they will provide for clinical settings. There's also an interactive guide on the National Domestic Violence Hotline, which is the hotline.org. And there's also a free phone app called My Plan, and that's also something which individuals can download to think about safety planning. So I appreciate your attention, and I'm going to turn it over to Amy Boyles.
Thank you, Dr. Amin. So I'm going to talk about our Intimate Partner Violence Assistance Program at the VA hospital. Nationally, we have an Intimate Partner Violence Assistance Program that is staffed individually at each of the medical centers and healthcare systems. So our vision is that veterans, their families, caregivers who receive care from VHA and VHA employees will not experience or use violence or abuse and will be free from those negative consequences. The mission is to implement a comprehensive, person-centered, recovery-oriented assistance program for vets, their families, caregivers, and employees who both use and experience intimate partner violence. So you can see from the graphic that it's veteran-centered, person-first, trauma-informed, and recovery-oriented, regardless of whether the individuals are using violence or they're experiencing violence. We know at the VA that intimate partner violence perpetration and victimization is more common in active duty than it is amongst our veterans, and it's more common amongst veterans than it is among the civilian population, with as many as up to double of the veteran population experiencing violence than the civilian population. Some reasons for this are some veteran-centric factors. We have higher rates of post-traumatic stress. There are specific military family life stresses, separation, isolation, multiple deployments, higher rates of mental health concerns, alcohol and drug use. We have loss of trust and moral distress, particularly among those deployed. Higher rates of traumatic brain injury, increased anger, and decreased frustration tolerance. This all can lead to increased risk for divorce, broken families, loss of their supports, with higher rates of homelessness, joblessness, and poverty, increased healthcare needs, justice involvement, and our higher rates of suicide and homicide in the veteran community. So with this in mind, we have implemented this program that involves raising awareness, IPV campaigns, materials, staff trainings. We build partnerships in the community, host outreach events, and participate in trainings such as these, all for those who both experience intimate partner violence and those who use intimate partner violence. We establish routine screenings, interventions, safety planning, and resources. And of course, for our VA staff, everything is available as well. So implementing universal screening, it was something that took place at the VA hospital last year. Before that, it was something that we did as clinicians thought it was necessary, as veterans disclosed what was going on. But universal screening looks like this. So step one is an environmental check. If anybody under the age or over the age of 2 is present, we ask to meet with the veteran alone. If that is not possible, then we simply indicate that the environment is not safe to proceed with the universal screen. And it's an annual screen reminder, so it'll pop up at every visit until it is satisfied. So the environmental check, if it's safe to proceed, we go to consent and to screen and consent to document. Documentation, as Dr. Amin was just explaining, can be very risky, especially for our veterans. We have a system called My Healthy Vet, similar, I think, to your My UPMC, where individuals can read everything that their doctor wrote. It's the entire note is documented and visible. So if we screen and we detail that the person has disclosed violence and what our plan is, then their partner could potentially see everything in their My Healthy Vet chart. We ask the veterans if they know that their partner has access or if they suspect that their partner may have access, and if they do, we change our documentation procedure. It looks like deleting the text from the note, writing a generic screen for relationship health and safety, and then the embedded factors from answering this templated question are still visible for healthcare professionals in our health factors. So the primary screen consists of 5 questions. In the past 12 months, how often did a current or former partner scream or curse at you, insult or talk down to you, threaten you with harm, physically hurt you, force or pressure you to have sexual contact against your will, or when you were unable to say no? This is the Likert scale ranging from never to frequently. If they answer rarely to even one of the questions, then it triggers the secondary screen. The secondary risk assessment consists of 3 questions. Has the IPV behavior increased in frequency and severity in the past 6 months? Has your partner ever choked or strangled you? And do you believe your partner may kill you? Any of those questions will trigger positive for the secondary risk assessment and require further assessment and safety planning. We offer the same disposition if they screen positive to the primary and screen negative to the secondary, or screen positive to both, in that we offer materials. We offer a consult to social work. It could be to myself as the IPV coordinator or one of our IPV champions. We offer safety planning. If a person screens negative, I've encouraged all staff to go ahead and continue to offer our safety plan. We have a small bookmark-shaped handout that folds up. I have it here, but I don't know that you guys will be able to see it. It folds up into the size of about half a credit card. So it can fit in a shoe, in a sock, in a bra. I have found that sometimes people will disclose violence but will not be able to leave with any information. They can't even put a phone number in their phone because their partner will check it. So if they're able to take this small safety plan, it has safety plan on one side, all the local and national contact information on the other side, then they're able to leave with a resource that they might be able to access later. We don't require you to disclose violence to have access to those resources, because someone shouldn't have to tell what's going on in their relationship if they're not comfortable and not be able to access all the resources and information. So I've tracked at the VA every consult that I've had in the past 3 years. And prior to implementing universal screening, my demographics look very different. So the VA population is approximately 90% male, 10% female. Prior to universal screening, my referrals were 71.4% female, 28.6% male. After we implemented universal screening, the referrals to my program are 48% female, 51.6% male. So females are still disproportionately represented, as is expected, in intimate partner violence. But what we found was that universal screening has given us access to individuals disclosing who we didn't suspect, who weren't coming forward with this information, and it has changed the services that we offer. So here's my contact information, and I will be available for questions.
Okay.
Hi
everyone. So today I'll be speaking about some of the emotional, social, and physical outcomes of IPV, including some data on psychological outcomes from Women's Center and Shelter of Greater Pittsburgh. So for IPV survivors, the negative health effects persist long beyond the abuse has potentially ended. In addition to a variety of acute injuries, which as described before, can include burns, lacerations, dental injuries, and brain injuries, IPV is related to worse chronic health and physical health outcomes. Starting with mental health, survivors of IPV report increased symptoms of depression, anxiety, suicidality, and substance use. There are also impacts on social functioning, which can include lower school and work attendance, lost wages, lower productivity, homelessness, and increased medical costs. And something that I think was less studied in the past in the literature relative to the acute injuries is the chronic health outcomes. And there's increasing work being done in this area. So a history of exposure to intimate partner violence is related to chronic pain, GI disorders, neurological disorders, HIV, unintended pregnancy, pregnancy complications, and of personal interest to my own research, cardiovascular disease risk and impacts on sleep. And what the data are showing in those areas, although it is still sort of early on, is that surprisingly, individuals who report a history of IPV are also more likely to report having a diagnosis of cardiovascular disease or having worse cardiovascular risk profiles. So this could be obesity, increased rates of smoking, or adverse lipid profiles. Sleep in particular is something that is interesting because a history of IPV is related to chronic fatigue, chronic insufficient sleep, and worse sleep quality. But also, sleep is something that can be controlled by abusers in terms of restricting access to sleep, awakening somebody, or overall disrupting their sleep. And unfortunately, the list that I just provide of health impacts is not exhaustive, and there are many other chronic mental and physical health impacts. We are incredibly fortunate in Pittsburgh to have the resource of the Women's Center. Over a decade ago, a group of individuals got together and formed the Programs and Outcomes Committee. And what their goal was to collect mental health and program utilization data to better inform the center on the women that were seeking their services, and also to make them more competitive with data-driven grant applications. And since 2013, I have been fortunate to serve on this committee. I was asked by my graduate school mentor, Dr. Karen Matthews, who is also involved on this committee, and it's really been a turning point for me to both understand the impacts in real time on the women that use their services. What we collect, I'm showing here is just a snippet. Some of the surveys that I thought would be of interest to this audience today are depression, perceived stress, self-esteem, and hope. And we collect these data points at entry when women enter the shelter, and when possible at 2 weeks and at exit. Those time points, the 2 weeks and exit, are not always available for everyone, depending on their own personal circumstances and how long they stay at the shelter. Exit typically can be about 4 weeks for women, but it also can be much sooner. And so just to give you some of the results, we are extremely fortunate that we have data on over 2,000 women at this point who have data on depressive symptoms at entry. And how we measure depression is using the PHQ-9, which I'm sure many of you are very familiar with. What we can see is that upon shelter entry, over half of the women are reporting severe symptoms of depression. And this severe category captures both the moderately severe and the severe categories as sort of coded by the PHQ scoring. Focusing on this severe group, this figure on the right shows the change in depression symptoms at 2 weeks in exit for women who enter shelter reporting severe depression symptoms. So the purple bars here reflect women who have data at 2 weeks. And what we can see is that about 1/3 of the women upon 2 weeks in shelter are reporting no change in their depressive symptoms. But what is encouraging is that by 2 weeks, over 50% of women are reporting a reduction in symptoms falling into the mild or moderate category, and 14% of women are reporting an even further reduction in their symptoms falling into the minimal category. The orange bars here show women with data at exit, and you can see by the ends that there is some drop off in terms of the number of women who have data across all 3 of these time points. So another thing here that is extremely encouraging to me is that by shelter exit, over 80% of the women are reporting a reduction in their depressive symptoms, with 1/3 of women moving from that severe depression category into the minimal symptom category. And these differences are both differences in terms of the clinical cut points for the PHQ, but they're also statistically significant. We also collect women's perceived stress using the perceived stress scale, a measure that's widely used in research studies. And again, we're fortunate to have over 2,000 women who have data on stress upon shelter entry. And what we see here is that 1/3 of women report feeling very stressed in the past 2 weeks, fairly often or very often upon coming into shelter. And what the purple and the orange bars show is that by the time they're exiting the shelter, that percentage of women who are reporting very high levels of stress has dropped below 1% as a result of the services and the supports that they're getting during their time in the shelter. Something I thought was also interesting and I think important to note here is women's self-esteem and hope. So the scales that we use don't have clinical cut points per se. So what I'm going to show here are just average scores. So they're specific to the women in our shelter and not necessarily comparable to national norms or other norms in research studies. Here, so what's important to take away here is that the max total score on the self-esteem scale is a score of 16, and the maximum total score in the HOPE scale is a score of 12. So at entry, we have women reporting scores in terms of their self-esteem of 12, and women reporting scores on the HOPE scale of 9. Those numbers, sort of taken on their own, don't seem that important because they're just numbers, but what we can say is that women are actually reporting relatively high levels of self-esteem and hope upon entering the shelter, and they report a statistically significant increase in those scales across their time in the shelter. And sort of taking all of these measures together that I just described, what I think is important to take away is that, not surprisingly, women who are experiencing abuse that is so severe that they enter into a shelter are reporting very high levels of severe depression and of stress, which is not surprising. But what I thought was surprising when I first started working with these data is that they're also reporting higher self-esteem and hope. And I think that's really important for us as clinicians to think about, that the work that we do can reinforce, can support that, and can also empower individuals in these circumstances to make changes in their lives that are feasible for them at the time. And I will say, I know I keep saying, using the word women. As I said before, the data that I'm describing here is only from women, but of course, as was mentioned in some of the previous speakers' talks, these are important things to be looking at in terms of men as well. And I just want to conclude with a perspective that was published in the New England Journal of Medicine in December 2020. This was something that really struck me. And basically, the authors describe that IPV during COVID-19 is really a pandemic during a pandemic. So the impact of stay-at-home orders and social distancing guidelines have had some impact in terms of individuals' ability to disclose abuse, to reach out for support, and to be safely connected to support. And the economic and social impacts that we're all aware of that are ongoing with the pandemic are serving to potentially further amplify the abuse that is currently happening. So even as we're entering a new phase in the pandemic in terms of initial distribution of vaccines, it's important for all of us as clinicians to realize that these impacts on health are long-lasting, will sort of follow the pandemic itself, and are things that we're going to have to think about as clinicians and researchers moving forward. Thank you.
Good afternoon. My name is Janice Goldsborough, and I'm the Medical Advocacy Coordinator at the Women's Center and Shelter of Greater Pittsburgh. I've been working with Karen virtually for going on 7 years now, analyzing our data. So I just wanted to give you some information, not only about the Women's Center and Shelter, but about resources in general. So this gives you the national number of the domestic violence hotline. So no matter what state you work in, if the patient or you calls this number, they will be, if they give information about what city they're in or zip code, they will be funneled to the center closest to them, or whichever one they would choose to use. Also, if you pick up your phone and dial 211, it's sort of a 911 for human services. So what that can do is give you not only domestic violence, but sexual assault, if the person doesn't have their utilities on, if they have an elder at home that they need help taking care of, that's a number that can give resources as well. So I did want to talk briefly about the Women's Center and Shelter and services that we provide. So our shelter stayed open throughout the pandemic. The pandemic hit in mid-March, and our shelter was open at that time and stayed open throughout. There are and were precautions taken because of COVID, but we are still taking in people as we have space. Now we consistently operate above capacity, which means that the extra space that we try to save and leave open in case we have an emergency has consistently been being used. So that's a good thing that someone's getting a space that they need, but it's not so great because we don't have the empty space that we wish we had, that we would allow someone to come. So our 24-hour hotlines, 412-687-8005, that's not only for a patient, for you to hand them the number and for them to call. That could be for you. If you're not sure a situation is reportable, a great example of this is that several years ago, I got a phone call from a social worker at AGH, and she said that the husband had waved a weapon around in the room with the 3-year-old, and she didn't know if that was reportable. Well, I wasn't sure, so I asked my supervisor. She wasn't sure. So what we were able to do was run down the answer for that instead of having a social worker having to do it on her own. Turns out it was reportable because it was loaded. Had it not been loaded, it wouldn't have been. So those are the kind of nuances that if you don't work with a subject every single day, you won't know. But the good news is you don't have to know. You could just give someone like us a call. We would find out the answer for you. I would like to be able to talk about all these services one by one, but I'm going to go down to the real team, refugees, immigrant, limited English speaking. So under that grant, we have 2 attorneys and 2 multilingual advocates. Well, everyone on the team is multilingual, and they have access to translation for whatever languages they don't speak. Now, that means in the shelter, or people that use what we call non-res, meaning just what it says, non-residential, you're using one of these many services without ever having stepped foot in the building. There's many services that you can get. So for the real team, that's documented, undocumented. We would never take steps to proactively inform law enforcement, although we do have to honor search warrants, we have to honor arrest warrants. And people usually understand, especially if they've been here a period of time, they don't have the documentation they need. They know once they go downtown to get a PFA and they sign their name, there's no, what people would think might be some sort of informal agreement because they're a victim of crime is not the case. So again, we do what we can to protect the person, but again, we have to honor search and arrest warrants. So these are something that we had printed out. We did a lot of things like this on the fly because this is unprecedented. When people called us, when domestic violence came to the forefront, when the pandemic hit, we were thinking this is a silver lining. Now people were starting to notice things like food insecurity, which is really in your face, and then domestic violence increasing. But unfortunately, the awareness of domestic violence is now going back down to pre-pandemic levels. The food insecurity is still there because you turn on the news and you see the lines at the food bank. So we have handed out, we tried to blanket the city and the county with this information. So when you're trying to hand information to people, or you have something hanging up in your exam room or something that you give patients, you give them a folder, it's always a tightrope. And we get inquiries now from agencies that serve people that have nothing to do with partner violence. For instance, the food bank, we just did a training with them. I don't know what they're called, I just call them phone answerers, but they're answering the calls that help people to get on Medicaid, and they help people to get on SNAP, which is food stamps. Well, the domestic violence is emerging, and these folks aren't experts in domestic violence, so we did a training with them to help them, literally give them things to say. This is what you could say to the person, this is how you can make a referral, and these are the places that you can refer to. But you walk that tightrope, like for instance, I'm looking at that line of cars, every time I see them on the news, I just want to throw a safety card in every single car. But of course you can't do that because you don't know who is in the car. You might look at a car with 2 women and say, oh, well, they're okay, and you wouldn't give them a card. Or you would look at a card with 2 men and think, well, that would have nothing. But as was mentioned before, it could be anybody. So there were cards that were given to the community. Unfortunately, I don't have a picture of them. They were 5 by 7, and they gave our information. So we took 1,000 of them down to the food bank and just said, do the best you can. So what we have come up with is when you want to give domestic violence information, embed it with something else. And like was mentioned before, call it relationship safety or whatever you can call it. Our first knee-jerk reactions was to say, don't give anything, but you have to try to do something. And again, we're figuring out this on the fly, because when this first started, we were getting phone calls from news agencies and so forth wanting to know about the increase in domestic violence, and all we had to refer to, we went onto the UN's website, and they discuss Zika and Ebola and sexual violence and things like that. And it's interesting because we're finding moms leaving the workforce, women more susceptible to sexual violence during Zika and Ebola, and there are correlations to that. So it'll be interesting to see 10 or 20 years from now what COVID-19 looked like. So as providers, you're part of a system that can help victims. So if you think about a domestic violence situation of long standing that has been reported, and there are people involved, there's police officers, there's a psychiatrist, there might be a school nurse, there's a dentist, there's a dermatologist, all sorts of people that weave in and out of that person's life. Your interaction with them might be closed-ended. You might have one crisis visit with that person, or you might see them weekly for therapy. But whatever it is, you're operating within your area of expertise, and when the domestic violence comes up, you consistently funnel them to the people that can be helpful. You don't try to put them off. Say, okay, at the end of the visit, we'll talk about that, and I want to give you some resources, but can we, or however you would say that, but you want to do that warm handoff to the people that are experts so that you can continue to focus on whatever it is that you're focusing on. Domestic violence may or may not relate to your obligations as a mandated reporter. In 14 years of this, and I don't even know how many patients I've seen, I have yet to work with a charge nurse to ever call the police against someone's wishes. So anytime there's a reporting, there will be an agency attached to it. So it's never a subjective decision that you have to make, because everyone in this room would make a different decision about when to call. So for instance, I'm going to skip down to another slide here. Child abuse, elder abuse, at-risk disabled, gunshot wounds, specific cases of sexual assault. There's an agency attached to all of those. Even with the sexual assault, the person might be 20 years old, and it might not seem like it's reportable, but the person could still be in the school system, and the person that perpetrated the abuse against them is a part of the school. So again, you wouldn't be expected to know those nuances, but just know where to call to get some help. So Pennsylvania does not have mandatory reporting for sexual assault, does not have mandatory reporting for domestic violence. There are a few states that have that. I'm really curious as to what that really looks like. But in situations where there has been what would have been reporting, the wounds were so severe and the person was brought by ambulance and the police accompanied them, and it's not something that you're going to see commonly. I, on a personal level and on a professional level, am glad that the pendulum swings towards HIPAA. It tends to swing towards the protection of confidentiality so the person can talk to their doctor or their provider knowing that their information won't be passed on against their will. And if it is, they'll understand the reasoning why. So the goal of intervention, the goal of your intervention, the goal of my intervention is to give the person the information that they need to make an informed decision. And I'm all about informed decision making. When I started this work many years ago, I cared much more about the decision. I was highly invested in the decision. I would go to people's houses. I was giving people my home phone number. And I was invested in seeing that situation through from start to finish. And now, fast forward 14 years, I figured out that I cannot do that. So I give the person every bit of information that I have that they can make an informed decision. A great example of that is the jail notification program. Another agency has a jail notification program. So if an abuser is arrested, once they're arraigned, they go into this system, and the people on that end check every 2 hours to find out the status. So that if your abuser bonds out at 8:30 on a Sunday, you made the decision to stay home. I'm sorry, my timer. You made the decision to not come into shelter because of jail notification. So if I give you that option, you say, okay, well then I'm okay going to my sister's house, because if they get out, then I'll know about it. And again, that can happen. People can be released by mistake. They can be released on a weekend, and you would never know, and you're sleeping at your sister's house and they're out. So I'm going to stop with this slide here. These 6 things, and I count them as 6 because homicide and suicide counted separately, they were identified in the mid-70s, and they have not changed since. So if in your narrative with the person, even if you're seeing them for something unrelated to domestic violence, because people sometimes become so desensitized to the danger that they're in, they'll tell you harrowing things that happen to them in a tone of voice that I would tell you that it's Friday. So what I say in cases like this, where the person says they've had a gun pulled on them, they've been sexually assaulted, they're being stalked, or different things happening to them, I tell them, you know what, in cases where a person was threatened to be murdered, or there are guns in the house, for instance, the possibility of a lethal outcome goes up several percentages, like I think 500% if there's a gun in the home. So I just tell people, you know, in my experience of doing this, when people have had strangulation ongoing like you have, they've been threatened with weapons, they ended up getting murdered. I really wish you would consider calling a shelter or calling this hotline. So that leaves them in part of the decision-making process. I'm not saying to them, well, I'm the expert and I really think you ought to call. It's still keeping them involved, but letting them know, because of this expertise that I have, you could have this sort of outcome. So if they don't agree to that, they still want to go back home, I say, okay, fine. Can we agree that if, and given their narrative, whatever permutations are involved in that, if it escalates to this point, that you'll call 911, or that you'll talk to a neighbor and keep a bag at the neighbor's, or that you'll keep your phone in your hand and charged as much as possible. And people say, okay, I can agree to that. So we came to a mutual decision instead of me saying to them, this is what you need to do. But when you hear any of these things, double down and be a little bit more assertive and let the person, you know, I tell them how I feel. I say, this is really scary. You know, you're hearing you say these words to me, how they pull the gun on you or held the gun to your head. That really scares me. I really wish you would consider getting help. But if you don't want to now, the option's always there later. No blaming or shaming. So that's all I have, and thank you much for your attention.
Okay, and we have a few other resources here in the PowerPoint, and that's really the end of our formal part of our presentation, but we left plenty of time for questions. So if you have any questions, all of our experts are here, and you can direct it to one or to all of us, but just unmute yourself because we don't have any way of reading a chat. So just feel free to unmute yourself and ask your question.
Dr. Glance, this is Jeannie. We did have one question from Dr. Barbara Duarte. I believe this was directed to Karen. Was there an intervention in between both measures?
Thank you for that question. So Janice may be able to step in on some of this from her work at the Women's Center as well. But what is interesting and tricky about that is that there's sort of multiple interventions. So depending on what the women are coming in with in terms of their particular circumstances, there are groups that are available to them. There's therapy that's available. Some women seek legal advocacy. Some women come with children and are thus, they are able to have their children be involved in different groups and activities so that the moms can take care of different things related to housing, employment, legal issues. So there are a number of different interventions, and myself and some other colleagues here actually at Pitt, so Dr. Lisa Borghese, who's in the Department of Immunology, and Dr. Sarah Goodkind, who is in the Department of Social Work, they also serve on the Program and Outcomes Committee. And we have been trying to do more sophisticated causal modeling, looking at the relationships between women's symptoms and reports upon entering, what services they take advantage of, and what their outcomes are. And that was really spearheaded by Dr. Borghese and some colleagues that she has at Carnegie Mellon, who can sort of do these very data-heavy, sophisticated analyses. So stay tuned on that. We're still in progress. We've recently worked with the wonderful staff at the Women's Center to get more data in terms of demographics of the women, so specific types of abuse that they have experienced, socio-demographics, other things that we can use to better understand what these women's experiences are and how they can be better served at Women's Center. So hopefully we will be in touch in the future with more specifics about that.
Do we have other questions, Jeannie, in the chat?
We did have one comment from Dr. David Kolko, just going down to it, who asked, do any of you work with those who are abusive?
Janice does. Oh, and Amy does too. So we've got two people to answer.
Hi, thank you. Thanks for that question. Yeah, so at the VA, we do work with those who use violence as well. And what we have is a Strength at Home program. So our program is a 12-week closed program that has a 2-hour group that meets once a week. I work with the victims of the violence, and I have 2 clinicians who run the group. It's a very strengths-based group, talks about identifying what they're feeling, learning to manage their emotions, frustration tolerance. It currently doesn't satisfy the court only because it's brand new. It does in certain parts of the country. It's a national program, so we're submitting it to Allegheny County courts for their approval. For those who do need court approval, I'm going to send it over to Janice right now because there is another program that we use for that as well.
The Women's Center and Shelter has what the acronym Men Embracing Nonviolence and Safety. So at first, it could only be court ordered. At the time of the preliminary hearing, our advocates would be available, and there would be an agreement made between the defense attorney and the district attorney that this person could be diverted if they met the criteria for the program. So it can be up to 6 months. The magistrate has the latitude to make it less than that, and sometimes they do. It is self-pay, but more for psychological reasons, not so much for the program to pay for itself because it does not. And the people involved in the program do not meet at the center. And there's also involvement with the partner. So this is men in this program. There's another diversionary program for women offenders, but this is for men, and their partners are sent a questionnaire and they're pulled into the treatment as well. And I don't know a whole lot about the program because its inception was maybe 8-9 years ago. There have been a lot of changes since. But what usually will happen, and also the person can call, it has changed from being court ordered only.
Should the charges be automatic that the officer shows up, there's a parent as well, the officer presses the charges or takes the part of that violence out of the equation as far as the arrest charges or not press charges, and second curious about what you colleagues think about the pros and cons of that approach.
Well,
Janice, if you would want to come up here, I think that they've got it figured out.
okay, I'll answer the question. So the question was whether or not there should be mandatory arrests.
Yeah.
The call itself is probable cause, but the police will always have discretion. So the Commonwealth is pressing the charges. If there are charges pressed, the Commonwealth is pressing charges. So that does take the onus off the victim. But the victim, their survivor, could then go on to not cooperate, to not show up at hearings. So the knee-jerk answer would be no, because of the way the system is set up. The survivor can avail themselves of all of that recourse. But if they're not going to cooperate, they're not going to cooperate, even if there will always be an arrest made. I hope I answered your question. Thank you.
It's a good idea or bad idea?
On a personal level, I'd say I think it's a bad idea. You just can't force people to do things. You just really can't. And again, the police have discretion. So if they come in, like, you remember the 60s and 70s when the police would come and say, we don't see any bruising, and then just walk away. The call itself is probable cause. Okay, and there's also the LAP program. So there's 3 questions that the officer asks the victim about their level of danger. And if the victim chooses, he will physically hand them his cell phone and they can call us, okay? And that person's given priority because their situation, could have a lethal outcome. So I'm, on a personal level, I'm just not about zero tolerance in any regard, because it just seems to not work. That's just on a personal level. Mm-hmm.
Okay, other questions?
Maybe a collective question. In the era of COVID and the hardship to telemental health services, any tips and tricks for trying to figure out home safety with the screen?
Anybody want to take that one?
Okay. So the question was, during the era of COVID and doing telemental health, tips and tricks for intervening and assessing for safety. I would say that the go-to should be to err on the side that there is somebody present or somebody listening. If you suspect, if you can hear noise in the background, it's better to not ask the questions, or to ask just a vague baseline question and move on if the person's uncomfortable answering, because we can't guarantee their safety. You can't know what's going on, and they can always be asked again at a later date, or at least they know that their clinicians are available. I always err on the side of somebody's listening when doing telemental health.
Thanks, and yeah, I would just add to that a situation that I had myself where I really thought something was reportable because of the situation where the child was involved, and I wanted to ask more questions, but I could tell that something was going on, and I just made a quick comment about, are you in a place where we could talk about this? And the answer was, oh, no, honey. So then we quickly changed course, but I reached out to the therapist and talked to the therapist about it and said, I'm going to report this because I felt like I had enough information where I really had to. I had no choice. But at the same time, I didn't have a chance to talk to her much about it. So in that case, working with the therapist was really helpful because then when the therapist met with her the next day, it was in a private situation and they were able to talk about it, if that's helpful.
We've received a couple of questions via chat for our speakers.
Okay.
The first one is for Amy. Regarding the VA IPV secondary screen, how were the 3 items selected? Is there evidence regarding their risk mitigation efficacy compared to some other possible questions to screen?
Thanks. The initial 5 questions are part of a questionnaire called EHITS. And the VA trialed that and rearranged the order and paid for the licensure or whatever. But we found that asking them in the order that went from like insult to higher severity sexual assault was more open, and we got more involvement. The 3 lethality questions are part of a danger assessment. It is the recognized miniaturized version of a longer standardized danger assessment. So those 3 questions were taken as our next level that would trigger a full-blown danger assessment, which is why the person has a warm handoff to somebody who's either myself, the IPV coordinator, or an IPV champion who's been trained in completing the danger assessment, the full assessment, and the safety planning.
We also have a question for Dr. Jakubowski. That question is, regarding the WCS self-esteem and hope measures, could there be a selection bias where those who entered shelter have different baseline characteristics which contributed to their successful entry compared to those who may still be in the unsafe environment?
That's a really great question and something that we've discussed in our meetings. There's certainly, I think, a selection bias there that somebody who has taken the steps to actually enter shelter and make those decisions is, potentially somebody who maybe has spoken to a clinician or somebody else to get, to feel empowered to do that. So they might be coming in both in a situation of danger, but also sort of having some hope that there is help, which is why they're going there. So there is a selection bias. I think the data, we have not compared the data that we have at Women's Center to data from other shelters. Part of that is because the data that we have, I think, is incredibly unique, that not all shelters have collected these types of data, and especially not with the sample size that we have. So I think it'll be interesting to do more of that and to see if there's something unique in particular about Women's Center and Shelter of Greater Pittsburgh. But that's a great question, and I would agree that there likely is a selection bias at play.
We also received a question for Janice. Catherine Swords would like to know, do Women's Center advocates still come to the hospital to meet with people who are interested in using their services?
I used to be that person. And when the pandemic first struck, I got a few calls and then the calls really dropped off. But I have developed a phone system so that on the rare occasion, I don't think I've had a call in about 6 weeks. But with the vaccine coming forth and changes, hopefully that's something that will change. But anyway, I have a phone assessment that I do over the phone with the person, and then I take down the information from them, and then I can, via email, pass that on to whichever department in the agency is able to be of most help for them. So But no, I stopped going into the hospitals when it first happened, and then I stopped getting calls. So I'm hopeful that the calls will start again soon. Does that answer your question in full?
Thank you. We have a comment for Dr. Amin and a question. Thank you, Dr. Amin, for highlighting the specific vulnerabilities of LGBTQ+ people. Are there shelters in Pittsburgh or Western Pennsylvania that are accessible to trans people?
Thank you for that comment. I'm also phoning a friend here because I know Janice is a little bit more aware of some of these resources. So I'm actually going to let Janice answer this question.
Thank you. I should have made this clear in my presentation. Our shelter serves everyone, even though it's named Women's Center and Shelter. It's just a matter of how services will be delivered. For instance, if a man calls us and needs sheltering, whether he's in a heterosexual relationship or a same-sex relationship, doesn't matter. We have the provision that we could put them in a hotel for a short time because the cost is prohibitive, and then we would look for something else that would be a little bit more long-term, maybe 30 days, the same 30 to 60 days that people get in shelter. We serve transgender people. We've had people, depending where they are in their transition, whether or not they would stay in a shelter, they could also avail the hotel option. So again, it would be a case by case, a matter of how it's delivered, but I really want to stress that we serve everyone, and we want everyone to be comfortable coming to us for help. And we also have a pet area. We're able for the ladies to bring their pets that are staying in shelter. Now that does not include a certified seeing eye dog. That dog would be with you all the time. Under the ADA, they wouldn't be required to sleep in the pet area. But we do have a place where people can bring their pets. So, and they can also bring children with them. Sometimes people chose to leave their children at home. Sometimes the children are in placement. We've had cases where CYF workers or other agencies would be bringing the children for visits, or mom would be going on visits. Sometimes they've left the kids with relatives so as not to disrupt their schooling. So any sort of combination of that, we're able to work with. But we take people who have children and people who don't have children. I want to be very clear on that.
If we could ask you just to stay there for a moment, Janice, we have a follow-up question for you. And that question is, can you tell me if there are limits to the number of kids, ages of kids, limit to one dog, one cat, etc. at the shelter?
No, the short answer is no. We've had one pet family filled up 3 of the cages with big dogs. And no, we absolutely do not have limits on children. We had a case maybe 12, 13 years ago. This lady's situation, she was coming from Philadelphia. Her abuser was so lethal that the staff in her personal vehicles brought her and her 9 children over to our center. And I can tell you, they were the best behaved kids. They were all like little ducklings following their mom along. And as far as space-wise,